In this video, we'll be going to discuss about the temporomandibular joint. Coming to the introduction, the temporomandibular joint is a joint between the temporal bone and the mandible bone. It allows the movements of the mandible for speech and mastication. The mandible is a single bone having two heads which articulates on each side with the temporal bone of cranium. The cranium with which the mandible articulates is also mechanically a single component. The movement that cannot take place at one temporomandibular joint without a concomitant movement occurring at the joint on the opposite side. Therefore, the temporomandibular joints are bilateral components of a single craniomandibular articulation or joints. That means both the articulations, right articulation as well as the left articulations, will be working together and functioning like a single joint. And coming to the type, temporomandibular joint is a synovial joint of condylar variety. So this is the sagittal plane cross section of a right temporomandibular joint. The mandible is in a position of maximal intercuspation with the disc in its ideal position relative to the condyle and the temporal bone. So you can see here the articular eminence and the mandibular fossa and the condyle and neck of the mandible. So this is the distal articulating surface and this is the proximal articulating surface, and inside the mandibular fossa, so you can able to see here articular disc attaching and which will be providing the stability to the temporomandibular joints along with your ligaments. So coming to the articular surface, the upper articular surface is formed by the articular fossa and the articular eminence of the temporal bone. This surface is concave or convex from behind forwards. The lower articular surface is formed by the head, that is the condyle of the mandible. This surface is elliptical in shape. The proximal surface, that is the upper surface, which is composed of articular fossa and the articular eminence of the temporal bone, which is concave or convex in shape, and the distal or lower articular surface, which is formed by the head or condyle of the mandible, which is elliptical in shape. So this is the articular surface of the temporomandibular joints. So this is the proximal articular surface and this is the distal articular surface. In between there will be a joint capsule, and the joint cavity is divided into two parts, upper part and lower part by the articular or intra-articular disc. The articular surface are covered by fibrocartilage, not by hyaline cartilage. Hence, temporomandibular joint is an atypical synovial joint. Coming to the joint cavity, the cavity of temporomandibular joint is divided into upper meniscotemporal and lower meniscomandibular compartments by an intra-articular disc of fibrocartilage. The upper compartment permits gliding movements. The lower compartment permits gliding as well as rotational movements. These 2 points are one of the important points which you need to remember, because this will be useful for your kinematics, arthrokinematics and osteokinematics of the temporomandibular joints. So come again, like the upper compartment permits gliding movements only, while the lower compartments permits your gliding as well as your rotational movements. So coming to the part of the intra-articular disc, so this is the parts of the intra-articular disc. So it includes your anterior extension, this is the anterior extension, and coming to the anterior band, this region is your anterior band, intermediate thin zone and the posterior band. So the posterior band is again attached into two different areas and it has been divided into two laminas. The posterior band is again classified into two laminas, that is the upper lamina and the lower lamina. So this will be attaching over this particular region. Coming to the articular disc, the articular disc is an oval plate of fibrocartilage. Though termed fibrocartilage, it consists mainly of collagen fibers with few cartilage cells. It is congruent with both the articular surfaces. Thus, its upper surface is concave or convex and its inferior surface is concave. The concavo-convex superior surface fits against the articular eminence and the concavity of the articular fossa. The lower concave surface fits with the convex head of the mandible. The periphery of the disc is attached firmly to the fibrous capsule. The disc has a thick margin, the peripheral annulus, and the central depression on its inferior surface. In sagittal section, the disc appears to possess a thin intermediate zone and thickened anterior and posterior bands. The anterior band extends anteriorly through the capsule to be continuous with the tendon of the lateral pterygoid. The posterior band splits into two lamina, upper lamina and the lower lamina. The upper lamina consists of fibroelastic tissue which is going to attach over your scomotympanic fissure. The lower lamina composed of fibrous non-elastic tissue which is going to attach over your back of the condyle. The bilaminar region contains a venous plexus and the central part of the disc is avascular. The elastic fibers in the posterior part of the disc bring back the disc in the articular fossa when the open mouth is closed. Coming to the ligaments, the ligaments of your temporomandibular joints includes your fibrous capsule, temporomandibular ligament, sphenomandibular ligament, stylomandibular ligament. So first one is your fibrous capsule. So fibrous capsule is a fibrous sac to enclose the joint cavity. So it is attached above to the articular tubercle, the circumference of the articular fossa and the scomotympanic fissure and below to the neck of the mandible. The capsule is loose above the intra-articular disc and tight below it. So above the intra-articular disc, the upper part of the capsule will be loose and the lower part of the capsule will be tight in structure. The synovial membrane lines the inner aspect of the fibrous capsule and the neck of the mandible. So in this diagram you can clearly able to see here the attachment of your fibrous capsule. So it is attached above to your articular tubercle and the circumference of your articular fossa and the scomotympanic fissure, and below it is attached over your neck of the mandible. So next ligaments which provides the stability to your temporomandibular ligaments includes your lateral temporomandibular ligament, sphenomandibular ligament and the stylomandibular ligaments. The attachments and the function will be explained in detail in the upcoming slides. So next ligament is your lateral temporomandibular ligament. It is a true ligament and formed as a result of thickening on the lateral aspect of the capsular ligaments. So actually this lateral temporomandibular ligament is the thickened part of your capsule of your temporomandibular ligament. Its fibers are directed downwards and backwards and it is attached above to the articular tubercle on the root of zygoma and below to the posterolateral aspect of the neck of the mandible. So superiorly it is attached over your root of zygoma of your articular tubercle and below it is attached over your posterolateral aspect of the neck of the mandible. This ligament strengthens the lateral aspect of the capsule. The lateral aspect of the capsule is strengthened by your lateral temporomandibular ligament. And this is the swing like structure or analogous structure formed by your ligaments, your mandible and your accessory ligaments. So this is formed by your sphenomandibular ligament, the stylomandibular ligament and your mandibular bone. So coming to the next ligament, that is your sphenomandibular ligament. It is attached above to the spine of the sphenoid and below to the lingula and the lower margin of the mandibular foramen of the mandible. So coming to the attachment, superiorly it is attached over your spine of the sphenoid, and inferiorly it is attached over your lingula and the lower margin of the mandible foramen. So this is the mandible foramen and it is attached over this region. So it lies a deeper plane away from the joint capsule. It becomes accentuated and taut when the mandible is protruded. So when the mandible is protruded means this sphenomandibular ligament will be getting tight. So coming to the relation, so laterally it is supported by your lateral pterygoid muscle, auriculotemporal nerve, maxillary artery, inferior alveolar vessels. Medially, it will be supported by your medial pterygoid, cauda tympani nerve, and wall of the pharynx. Represents your relation of your sphenomandibular ligaments, both your superficial relation as well as your deep relation. So laterally it is supported by your lateral pterygoid muscles, auriculotemporal nerve, maxillary artery, inferior alveolar artery and your inferior alveolar nerves. So these are the lateral relations, and medially it is connected by your medially the relations include your medial pterygoid muscles, cauda tympani nerves, and valve of the pharynx. The next ligament is stylomandibular ligament. So it is attached above to the lateral surface of the styloid process and below to the ankle and the adjoining posterior border of the ramus of the mandible. So this is attached over the lateral surface of the styloid process and below to the posterior border of the ramus of the mandible. The stylomandibular ligament is formed due to the thickening of the investing layer of deep cervical fascia, which separates the parotid and submandibular glands. These ligaments also become taut when the mandible is protruded. So similar to your sphenomandibular ligament, stylomandibular ligament is also will get tight during the mandibular protrusion. So coming to the relation, the laterally, the stylomandibular ligament is related with your skin and fascia, parotid gland, temporal branch of the facial nerve. Medially, it is related with your tympanic plate, separating it from the internal carotid artery, spine of sphenoid, auriculotemporal nerve, middle meningeal artery, sphenomandibular ligament, chordae tympani nerve. Anteriorly, it have relation with the tendon of the lateral pterygoid, mesenteric nerve and vessels. Posteriorly, it have relation with the postglenoid part of the parotid gland, separating it from external auditory meatus, superficial temporal vessels, auriculotemporal nerve. Coming to the nerve supply, the temporomandibular joint is supplied by two nerves, that is the auriculotemporal nerve and mesenteric nerves. Auriculotemporal nerve, its articular twigs enters the joint from its posterior aspect. Mesenteric nerve, its articular twigs enters the joint from its anterior aspect. So the anterior aspect of your temporal mandibular joint is supplied by your mesenteric nerve, and the posterior aspect of the temporomandibular joint is innervated by your auriculotemporal nerve. Coming to the blood supply, the temporomandibular joint is supplied by two arteries, that is the maxillary artery and the superficial temporal artery. The articular twigs of these arteries enter the posterior aspect of the capsule. Coming to the lymphatic drainage, the lymph from the temporomandibular joint is drained into superficial parotid or preauricular lymph nodes, deep parotid lymph nodes, upper deep cervical lymph nodes. Coming to the stability, the joint is much more stable when the mouth is closed, that is when the teeth are in occlusion, than when the mouth is open. So comparing to the mouth open and mouth closed position, the joint is more stable during the mouth in a closed position. In occlusion, the teeth themselves stabilize the mandible on the maxilla, and no strain is thrown on the joints when an upward blow is received on the mandible. Further, in the occluded position, the forward movement of the condyle is discouraged by the articular eminence and by the contraction of the posterior fibers of the temporalis muscle, while the backward movement of the condyle is prevented by the lateral ligament and the contraction of the lateral pterygoid muscle. Coming to the movements of the mandible, when the temporomandibular joints of two sides are in position of a rest, a small free space exists between the upper and lower teeth, but lips are in contact. The various movements of mandible occurs in this position. The lower jaw can be depressed, elevated, protruded, retracted, and moved from side to side by the movements at the temporomandibular joints. So mechanism, all of the above mentioned movements of the lower jaw involves two basic movements which occur at the temporomandibular joint, of course with the help of the muscles. So these two movements are your gliding movement and the rotational movements. The upper meniscotemporal compartment of the temporomandibular joints permits the gliding movements during protraction, retraction, and chewing. The lower meniscomandibular compartment permits rotation around two axes, that is, transverse axis during depression and elevation, and in the vertical axis during the side to side or chewing movements. With these two types of movements, gliding and rotation, and with the right and left temporomandibular joints working together, most of the movements of the lower jaw can be accomplished perfectly as desired. These include opening and closing the jaws and shifting the lower jaw to one side. So these are the movements of the lower jaw related to the temporomandibular joints to show the opening and closing of the mouth. So note the changing relation of the condyle of the mandible. So during mouth close, you can see here the articular eminence and the condyle or the head of the mandible is within the articular eminence or the articular fossa. So if you are tending to open your mouth, you can see here there is an anterior movement of the articular disc as well as your head of the mandible in comparison with your mouth closed position. So the movements occurring at the temporomandibular joints are depression, elevation, protraction, retraction, and side to side or chewing movements. So first we are going to discuss about the depression, that is the lowering of jaw to open mouth. So during depression, the head of the mandible along with the intra-articular disc will be gliding forward in the upper meniscotemporal compartment on the both sides by contraction of your lateral pterygoid muscles. At the same time, the head rotates forward underneath the articular disc by the contraction of suprahyoid muscles via digastric, geniohyoid, and mylohyoid muscles. The gravity also helps in opening the mouth. So during depression, the head of the mandible will be gliding forward with the help of the articular disc or along with the articular intra-articular disc. So next movement is your elevation, that is elevation of jaw to close the mouth. So during elevation, the head of the mandible along with your articular disc will be gliding posteriorly in the upper meniscotemporal compartment by the temporalis, masseter, and medial pterygoid muscles. Then the head rotates backward on the lower surface of the disc by the posterior fibers of the temporalis. So during elevation, the head of the mandible along with the articular disc will be gliding posteriorly. Next movement is your protrusion or protraction. During this movement, the mandibular teeth will be moving forward in the front of the maxillary teeth. In this act, the head of the mandible, along with the articular disc, glides forwards in the upper temporal compartment on both sides by simultaneous action of your medial and lateral pterygoids on both sides. So during protrusion or protraction, the head of the mandible along with the articular disc will be gliding anteriorly. Next movement is your retraction. During this movement, the head of the mandible along with the articular disc will be gliding backwards in the upper temporal compartment by the contraction of the posterior fibers of the temporalis muscle and bring the joint in the resting position. The forceful retraction is assisted by the deep fibers of masseter, digastric, and geniohyoid muscles. At the end of this movement, the head of the mandible comes to lie underneath the articular tubercle. So during retraction, the head of the mandible along with the articular disc will be gliding posteriorly, and retraction is the resting position of the temporomandibular joint. So during this position, the mandible will be coming to lie underneath the articular tubercle. Next movement is your side to side or chewing movements. These movements occur alternately in the right and left temporomandibular joint. In chewing movements, the head of the mandible on one side glides forwards along with the disc, but the head of the mandible on the opposite side merely rotates on the vertical axis. As a result, the chin moves forward to one side, that is towards the side on which no gliding has taken place. During this movement, the medial and lateral pterygoids of one side contract alternately with those of opposite sides. The alternate movements of these sides result in side to side movements of the lower jaw. So coming to the muscle producing the particular movements. So depression, that is opening of mouth, it is mainly produced by the contraction of the lateral pterygoid along with the support of the gravity. And the supporting muscles includes your digastric, geniohyoid, and the mylohyoid muscles. Next movement is your elevation, that is the closing of your mouth. It is caused by the medial pterygoid, masseter, and temporalis, vertical fibers of your temporalis muscle. Next movement is the protraction. So this protraction is produced by the lateral and medial pterygoids along with the masseter muscles. Retraction is produced by the posterior fiber of the temporalis muscle, and it may be assisted by the middle and deep fibers of the masseter, digastric, and the geniohyoid muscles. Side to side or chewing movements. These movements are performed by the alternate contraction of the medial and lateral pterygoids on each side. So as a summary of the movements, so the depression is produced by the lateral pterygoid mainly, supported by the digastric, geniohyoid, mylohyoid, and gravity. Elevation is produced by the masseter, medial pterygoid, temporalis muscle. Protrusion or protraction is produced by the medial pterygoid or lateral pterygoid muscles, and retraction is produced by the posterior fibers of the temporalis muscles, and side to side or chewing movements by the medial and lateral pterygoids of one side contracting alternately with that of opposite side. So coming to the clinical correlation, first one is your dislocation of the mandible. So this mandibular dislocation happens mainly over your anterior aspects. So the mandible is dislocated only anteriorly. When the mouth is open, the mandibular condyles move forward and lie underneath the articular eminences. This is the most unstable position of the temporomandibular joint. In this position, if there is an excessive opening of the mouth, as during yawning, sudden violence, or convulsive spasm of the lateral pterygoid muscles, the head of the mandible of one or both sides may slip anteriorly and get locked in the infratemporal fossa. So in this diagram, you can able to see this. This diagram is the normal one. This is the normal temporomandibular joint, and this is the dislocated temporomandibular joint. In this, you can see during normal or during mild opening, the head of the mandible will be within the articular fossa. So during excessive opening or yawning or the contraction or violent spasm of the pterygoid muscles, there will be the head of the mandible will be dislocated anteriorly. So this is the anterior dislocation of the temporomandibular joint. As a result, the mouth cannot be closed anymore, and any passive effort to do that will invariably fracture the neck of the mandible on one or both sides. To reduce dislocation, the condyles must be lowered and pushed back behind the summit of the articular eminence into the articular fossa. Thus, the reduction is done by depressing the jaw with the thumb placed on the last molar teeth and simultaneously elevating the chin. So next clinical correlation is your temporomandibular joint syndrome. This syndrome consists of group of symptoms arising from the temporomandibular joints and their associated masticatory muscles. The typical presenting symptoms are diffuse facial pain due to spasm of masseter muscle, headache due to spasm of temporalis muscle, jaw pain due to spasm of lateral pterygoids. These symptoms may be associated with clicking and pain in the joint. The clicking is often audible when the patient is chewing. It occurs when the posterior attachment of the disc becomes stretched or detached, allowing the disc to become temporarily or permanently trapped anteriorly. The dearrangement of the articular disc results from an overclosure or malocclusion. During surgery of the temporomandibular joints, the facial nerve should be preserved with utmost care. This is all about the temporomandibular joint. Thank you for watching. Please do share this video to your physio friends and fraternity. Thank you.